Hi, my name's Linda Clerihew. I'm a paediatrician in Dundee, and I was historically the national lead for the Paediatric Patient Safety Programme, or the Paediatric Workstream of McQuick. We've recently started introducing a national paediatric early warning score across Scotland with the intention of using that in all environments. We've been asked by a number of boards what the history in developing the PEWS has been and what we've done to try and make sure we are not introducing new risk by moving on to this system. So the chapters that we're now recording and uploading online are really to give you some background and understand the processes that have been going through and all the testing that has been going through over the last 2 or 3 years in Scotland in developing the Paediatric Early Warning Score. So really the question is, well, what is the evidence for the best PEWS? What do we know already, and how can we take this and use it in practice? If there is a best PEWS, is it the best in all environments? So we're wanting this to work in the pre-hospital environment as well as the hospital environment, and in a variety of different hospital environments, all the way through from the front door to intensive care. Are there specific subgroups of patients where actually a different paediatric early warning score may be required? So how can we make this work for everybody? In previous chapters, we've looked at the literature review that we've undertaken to show that we've chosen the most appropriate physiological parameters, and the most appropriate ranges, the most appropriate ages for charts, etc. We've also quickly looked at the Delphi process that we undertook, trying to understand where we were in 2012 when we started working on a national paediatric early warning score. So what did we know from the charts that were in use at Scotland at that point? This chapter really looks at how we understand what data we had in Scotland at the time we started with paediatric early warning score, moving to that being a national one, and how we could utilise all that knowledge and experience and try and distill it down into making a better chart than perhaps were in use already within Scotland. So we'll be spending about half an hour just looking through all the different testing that we have done over the last 2 or 3 years. So in 2012, what evidence do we have that one chart was better than another? Was the one that was performing best in Scotland? Well, actually, what evidence we had was that all boards were using paediatric early warning scores. So they had charts, they were using them, and actually for 95% of patients across Scotland, charts were being completed for the right age of chart, for the right child at the right time, and the score was being calculated correctly. Now that data comes from monthly reporting from the boards. Each board are asked to sample 20 patients, 20 charts, and look at how accurately these are being completed. That data was then submitted in nationally and collated and looked at across the whole of the country. What we did have was the fact that we were using charts, but actually we could see there was variation in how children were being escalated if they were unwell or if they had physiological changes. Now this slide is relatively complex. I need you to think about this as being national level data rather than a specific board. The green line along the top reports, so this is nationally collated data for 14 health boards in Scotland. The green line along the top shows the highest reported data compliance that month. The blue line along the bottom shows the minimum compliance reported by any board in Scotland that month. So month on month, the green dots may represent different health boards and the blue dots may represent different health boards. What it shows is the gap between the blue line and the green line is a variation month on month within Scotland. And the yellow line across the middle is a median. So by 2012, we were showing that 98 to 100% of children admitted to an inpatient unit within Scotland were having their observations plotted on a paediatric early warning score chart of the correct age for that child. Taking the same children and the same charts, when we looked at how accurately the score was being calculated, we found that actually the median across Scotland was between 85 to 95% being calculated correctly. If your score is not calculated correctly, then it's very difficult to escalate appropriately. And what you can see in that middle chart is there's huge variations. That blue line varies significantly from 0% up to about 80%. Now over time it starts to improve, so the variation reduces, but actually the blue line comes up to around 90% at best for the last few months of that reporting in 2012. When you then take that you've got a sick child, their observations are being plotted in a paediatric early warning score chart. Chart is then being scored, but about 10 to 15% of the time is being scored inaccurately. We then look at how that care is being escalated, and we find again there's a huge variation. with the median sitting between 75 to 95% of children who have observations sitting within the escalation threshold that their care is escalated appropriately. Now, we don't have details of what it was that was leading to this gap between reporting and escalation, but certainly we felt there must be something in this for us to understand. We feel there must be something in it for us to understand what the variation is in being able to score correctly, and if the charts are scored correctly, then what's leading to this variation and escalation. You'll have understood from the previous chapter on the Delphi process that there was really two main systems in use in Scotland, and they were different scoring systems, but also different escalation systems. So, where are you being escalated on a certain score? Where are you being escalated on concern? Where are you being escalated because you had two parameters in the yellow range and one parameter in a red range? There was quite a huge variety between that. What we do know is that each board had set their escalation thresholds slightly differently and on different numbers and in different contexts. But generally they fell into the two camps of using a traffic light or a binary chart, which we'll discuss later. In addition to this, we'd also looked at which observations scored and which didn't. And one of the big discussions we had when we were coming to develop the National Paediatric Early Warning Score was this growing concern from clinical frontline staff who were involved in the working group that actually we were starting to talk about the fact that PEWS wasn't everything. So the score itself wasn't everything. And sometimes we were escalating sick children who had a very low paediatric early warning score, but there was significant parent or doctor or nurse concern. Similarly, we may say children who scored relatively highly, but actually staff weren't concerned. So we weren't sure how much of the escalation process was dependent on the number, i.e. the PEWS score, how much was actually dependent on the staff concern round about that. The only thing we can really quantify by looking at the charts and scoring systems is the score, but we felt we really had to look at both the score and whether we took into consideration the concerns at the same time. This next bit of discussion really focuses more around the scoring system than whether we did or didn't adopt scoring for parental concern. The whole premise of a paediatric early warning score is that we take physiological parameters. Physiological parameters change over age, so our heart rate changes. What is normal for heart rate changes over age. Same with respiratory rate and blood pressure, etc. Really what we're doing is superimposing colour into a chart to make it easier for people to recognise when a physiological parameter falls out with the normal for that age range. We're not relying on us all remembering what is normal at 23 months in the middle of the night. Most systems in use in Scotland followed a traffic light system. So you could either score a 0, a 1, a 2, a 3 or a 4, depending on how far out with the normal range a physiological parameter was. But there was also one system where we used what we called a binary system. So either you scored a 0 if your physiological parameters were in the normal range, or a 1 if they're out with the normal range. And there were really strong feelings being voiced in the working group that one system was better than another. And there was really strong believers in the traffic light system, and there were really strong believers in the binary system. We did wonder whether some of the difference in the score, so if you remember we were recording PEWS and reporting PEWS reliably, but actually we weren't counting very well, so the score wasn't counted correctly in about 10 to 15% of cases. And we do wonder whether some of this variation in counting properly and escalation was attributed to how difficult the scoring systems were to use, and we aimed to go out and test this. Before we went out and tested it, we actually asked some frontline staff what they thought. So we took a traffic light chart and a binary chart into 4 of the boards. We went round and asked staff what they actually thought of the charts, whether they thought that one was better than another. We'd looked up the evidence. We know there's no published evidence that one is better than another in clinical practice. And then the results were actually fairly interesting. And in the 4 test sites we went into, test site 1, who usually use a binary chart, 19 staff out of 27 preferred using the binary. And their comments included it being clear, it was simple, I know when to escalate, I won't be criticised by medical staff for calling, qualifying that statement by saying I've used the traffic light system previously and I got shouted at when I called for help in the yellow zone. Test site 2, who usually use a traffic light system, were interested and had similar comments about the binary system. Now, many staff had never seen the binary system, so this introduction of a different system into units caused a lot of discussion. When we flipped it round and looked at the traffic light charts in each of the boards, the team who used the binary system had 7 staff who preferred the traffic light. All of these staff were very junior, either last year as students or first year qualifying, and their comments were quite enlightening too. They said, I know I don't have to worry until I'm in the red, so I can just ignore things when they're in the yellow and the amber. I know I can monitor for a while before I respond, whereas in the binary it goes straight to red and therefore I have to escalate. They also said traffic light means there's too many calls to doctor. Another staff commented that it must be better because it's graded, suggesting that it must be more sensitive. Comments on either side of this were interesting. What we decided to do was actually go out and test these charts in clinical practice. So, in the 4 test sites who had volunteered to be involved in the testing of the binary chart versus the traffic light chart, we agreed to go out and randomise in a simulated patient to ask staff who were on the floor that day, so just the frontline staff who were on the ward, to plot a set of observations either on a binary chart or the traffic light chart. We did 2 things. We measured the time to complete the observations and we looked at the accuracy of completion. Now, we'd intended going out and doing this test in 4 boards. Really interesting. 2 of the test sites could not get as far as testing because they were so convinced that their own chart was better, and there was huge resistance moving to a new chart that they wouldn't even test the new charts in simulated practice. The other 2 test sites went on with their testing. Now, test site 1 usually uses a binary system, and test site 2 usually uses the traffic light system. What they did was randomise half the staff to plot on one and half the staff to plot on another. In test site 1, who usually use the binary system, they found that using the binary system, they could complete the observations faster than they could completing the traffic light system. And this held true for the team 2, who usually use the traffic light system. So there's a significant difference in the time to completion of observations. Now, for me, looking at this data, I believe that that is useful information to have. It suggests that a binary chart is easier to complete, that we're not using our cognitive load to count a sum all the time, and therefore we'd have more time at bedside to look at our patient. For other staff, it raised concern because they felt that we should be spending more time beside the patient, and therefore the longer it took to complete the observations, this suggested they were spending more time with the patient. I think we could interpret this either way, but I would be concerned that the time spent beside the bedside was indicative of time spent doing a sum rather than actually observing the patient and interacting with them and looking at all the other non-physiological suggestions we could get that the child was unwell. In that same simulated exercise with a simulated patient in the bed with an iPad with a set of observations on it to be plotted onto the chart, we again, looking at test site 1 and test site 2, looked at how many of the charts were completed correctly and how many were scored correctly. Test site 1 and the test site who usually use the binary system, what we found is that all of their charts were completed correctly in the binary system and all of them are counted correctly. Using a traffic light system, there was a significant reduction, so it was difficult for this team to complete a traffic light system. Test site 2 are used to using the traffic lights, so actually they were plotting these observations on their normal chart. We also found that actually they had challenges completing the chart correctly, with only 82% of charts being completed correctly. This is a chart that this team normally use in practice. When we actually looked at whether this counting was done properly, the scoring, we found that 100% of charts were counted correctly if using binary in both sites, whereas less than 15% of charts were counted correctly if using a traffic light. And again, this is on both sites, so one of these teams usually uses this traffic light system. This, to me, is a hugely alarming piece of information. We're spending more time plotting our traffic light chart. We might plot it correctly, so we might plot the observations in the correct space, but actually we cannot count them and we score them incorrectly 85% of the time. Now, if we are incorrectly calculating a paediatric early warning score, how can we reliably escalate for the child who's unwell? This got us thinking really about, as we're moving forward with the national score, what do we do? There was huge resistance to everyone moving to just a binary score, primarily because staff were concerned that this was too simplistic and would give us false negatives, so we'd miss too many children. We did wonder, however, if we made it slightly simpler, so instead of scoring a 0 to a 4 or a 5, as it is in some boards, the traffic light system, so we just moved to a 2-colour system, whether we could make this easier. What we did then was designed up a chart based on that premise, that you could have a chart where there was white and scored 0 if the physiological parameters were within the normal range. You could have a 1 or a yellow if they were just outside the normal range, and you'd score red at the extremes of the normal range in hospital. We drafted up those physiological parameters. We'd asked the health boards to look at their last 10 deteriorating patients, so the last 10 patients that moved from a ward to intensive care unit, and asked them to look at their current paediatric early warning score versus a new paediatric early warning score, and whether this new chart would have recognised the patients at the same time, earlier or later, if they'd been using the new testing system. So that was the first test that we did. For the boards that reported back in on this, the new scoring system identified the patients either at the same time or earlier than the scoring systems currently in use in boards. And we felt reassured by this as we moved forward. So essentially we decided we were going to move forward with human factors work, and we were going to go out and do this simulated testing in more boards. So what we did was drafted up that test chart, and we took the chart out into 2 boards and tested it there. We got the data back from real staff, from real patients. We made some further human factors changes, and then we took it into a national networking event where there was about 60 staff present, and asked them to look at the chart, break it up, document the things they liked about it, they didn't like about it, move things around so that things flowed, highlighting factors to us that made the charts difficult to use, so actually using bolder text, bigger text, outlining things properly, having to put in some explanations that we hadn't thought of before, like explaining the mathematical signs of greater than or less than, explanation of what systolic blood pressure versus diastolic blood pressure was, and organising things in a logical ABCDE fashion. Once we'd redrafted our chart, we decided we were going to go back out and do the simulation testing that we'd previously done in all the health boards. So what we did was took our drafted chart and into each of the health boards and got the staff who were on the floor each day, and we randomised them either to plot the observations for simulated patients, so simulated patients in a bed with an iPad with a set of observations on it, and randomised them either to plot on the new national chart or plot on the current chart currently in use in their boards. So these frontline staff should have been very, very used to using their own charts already, as these charts have been used for a number of years. And we did this testing in 9 of the health boards, and the data we received back in for that was interesting. Now we are going out really primarily to prove that the new chart wasn't going to introduce new risk to each unit, because we're concerned that staff are used to using one system, that changing to another may introduce new risk. We can only do this in simulated practice, we can't do it in real practice to start with, until we know that we aren't introducing risk. The boards were quite enthusiastic about this, as well as getting to plot things on the new charts. They were obviously able to feed back about the human factors side of things and make charts and changes and adaptations to the layout of the chart, etc., as we went along. And as such, this testing really drove clinical engagement from the frontline clinical staff who were going to be using this national chart in the end. What we found was interesting. So each board, half the staff would be randomised to use their current chart, half the staff would be randomised using the new chart. There was no teaching and training done on the new chart. We literally put the chart in and asked people to plot the observations on it, look at the escalation thresholds, and then tell us what they would do with the score they had found. For 5 of the boards, staff plotted better and more accurately completed the charts and correctly counted the score on the new paediatric early warning score, for which they'd had no training, than they did on the chart that was currently in use in their board, which they've been using day in and day out for many months. For 2 of the boards, the performance changed slightly, with a lower performance in the new national chart than on the current chart in use. And for 2 of the boards, there was no significant difference. What's really interesting, if you look at the pale blue lines on this chart, that represents the current charts in use in each board. And there's a huge variation in how reliably these charts are being plotted, counted, and the scores are being calculated for these, with a number of boards showing that their current charts in use, they're only scoring correctly between 60 and 70% of the time. Surely there's something in this that then triggers the poor escalation that we're then seeing. Surely there must be a way of us making this simpler. So we then went back and put all the human factors things back into the charts that we had done. We went back out to testing the new versus the old charts, and we also went back out to testing the new chart versus the original binary chart that we'd used, and we did this in 2 health boards. What we're pleased to say is that actually testing the binary chart and the new National Paediatric Early Warning Score chart, which is a two-point system, there was no significant difference in the reliability of scoring and accuracy of counting the score correctly between the binary system and the new counting system, i.e. across the nation, having done that testing, we were not introducing new risk. We weren't making things less safe. We weren't making it a bigger challenge to count the correct score in any of these health boards. When we compared using the old charts in each board, so taking all the collated data across the nation with the charts currently in use versus going in with simulation testing of the new charts, we found there was a marginal difference, but not statistically significant, between using the new national chart versus the old chart. So what we can say here is that there's no evidence that we are introducing new risk by moving to the new national scoring system. What we can say is that this is simulated practice, that these teams had not seen the new national chart at all, and therefore it's relatively easy to go out with a new national chart and plot it correctly. Now clearly we would be far happier if people were plotting it correctly and counting it correctly 100% of the time, but we do wonder if we can go in and do the training, whether we can therefore then get that accuracy of documentation and calculation up to nearer the 100% with some training. So as you remember at the start of this presentation, we were talking about trying to use the same common language across the whole nation, so from pre-hospital environment through to ITU admission. Now actually, PEWS aren't validated for pre-hospital use at the moment. This is purely about us having a shared understanding of what a sick child looks like. This is purely having a shared understanding of what the normal physiological ranges are. This is purely on the phone when somebody's referring me a patient. If they're referring to the same scoring system, it is much easier for me to get that shared mental model of what that patient looks like. There is some validation work going on pre-hospital just now. But what we really want to know is actually, how can we use this scoring system that we've developed across the whole system, and are we introducing any risk by trying to do so? So what have we done to try and validate it across the whole patient journey? Well, currently there's very limited pre-hospital testing going on for any paediatric early warning scores. We have one out-of-hours centre in one of the health boards testing this new national PEWS for referral into hospital and documenting what the PEWS score are pre-hospital for staff to then document it on arrival and look at physiological change over time. We have not set an escalation threshold on that. We have not set a numerical target for hospital referral. We're literally just looking at the pattern of the scores that we see pre-hospital and who comes in. There's a pre-hospital validation process going on within the Scottish Ambulance Service. The final data for that study are awaited, but it includes 110,000 patients using this National Paediatric Early Warning Score and seeing whether it can predict adverse outcome, including intensive care admission or death. Other testing has been done in clinical testing as we've gone through with developing the new National Paediatric Early Warning Score, and have been done in single boards. So 3 or 4 boards have been included in this testing, each reporting in a different area. Essentially looking at round about 200 patients in each of the clinical environments, so front door environments through to inpatient wards, and then as patients are escalated up through single board HDU. What we have done, and we'll show you this later, is managed to look at how the National Paediatric Early Warning Score can predict ITU admission in a single unit. So how do we know that our PEWS is good? Well, how would we work out what's good about it or what's not good about it? How do we know that ours is better than anyone else's? Well, a perfect PEWS would identify all the sick patients and not let us falsely identify anyone who wasn't sick. That perfect world, I'm afraid, probably doesn't exist in the context of a paediatric early warning score. So we want it to be sensitive enough to pick up deteriorating patients, but acknowledge it may pick up some false positives. What we want to make sure is it's not picking up too many false positives, as too many false positives leads to bleep fatigue or numbing to the deteriorating patient. We'd want it to be specific, i.e. we want it to identify sick patients, but we don't want it to be only identifying sick patients, because in that situation we may miss some sick patients who score low or are false negatives. We want that perfect balance between sensitivity and specificity. We want to know which score we should be escalating on. And what we've done is looked at those single board data to see how commonly we see each of the scores. So taking things through from front door, in a single ED department, we looked at 177 consecutive patients. We have set a threshold of escalation of PEWS at around 5. This was for our clinical testing. We felt that a 5 was really the threshold for our maximum level of escalation. In the ED department, 177 consecutive patients, some of which will be trauma and some of which will be acute medical illness. Only 3% of children score 5 or more. So actually it's relatively uncommon to see a score as high as that. Therefore, it's highly unlikely we're going to get to bleep fatigue or numbing in that environment. Same holds true in a paediatric assessment unit where patients are relatively undifferentiated. Again, it's about 3% of patients will score more, 5 or more on admission or on arrival into the assessment unit. Now clearly, once you are differentiated and you move into inpatient units, we should see that actually we're seeing more patients with higher scores. This would suggest that lower score children are well and discharged, those who are higher scores were admitted. And what we do see is that normal variation changing slightly. So looking at 275 consecutive patients in an inpatient unit, what we found that only 4% of all observations are 5 or more. So again, a low number of observations are 5 or more. However, at some stage in their journey and during their admission, 16% of inpatients will score 5 or more. What this really suggests is that patients come in unwell, but given the right treatment and their score drops off over time. So over time, at any time in hospital, you'd be expecting about 1 in 20 to 1 in 25% of patients scoring more than 5 or being in your escalation threshold. So that's really about 1 patient per ward, which probably ties in with what we would find when we were talking about watchers and patients with high PEWS that we'd want to be watching more closely. So really we felt that the score of 5 is about the threshold we want to escalate on. We look at patients moving through the system, so getting sicker, and those going into HDU, again we would see more patients with a higher score. So about 1 in 4 patients will score more than 5 at admission. 35% of them will score more than 3. We look at ITU admissions. We've been fortunate enough, and we're very grateful to Sue Chapman, who's an intensivist at Great Ormond Street, who has looked at our scoring system and compared it with other charts in use across the UK. She has a cohort of 300 patients who have deteriorated and required admission to intensive care, and has compared them with 300 control patients. Our chart comes out with an area under the receiver operating curve of 0.81. So this is this balance of sensitivity versus specificity. You're looking for a score of more than 0.5 being good. 1 would be absolutely perfect. So a score of 0.81 is pretty good and would be into the pretty high performing range. In comparison with the other charts that were looked at within that study, across Dr. Chapman's comparison study, out of the 18 charts, ours comes out at number 9, really in the middle of the pile. What we have done, however, is looked at those charts towards the top end of the score and realised that they have a more complex system in place where they're scoring between 0 and 4 for each physiological parameter. We had obviously rejected using complex systems earlier on due to the human factors work that we'd done with the simulation testing in boards. So this really summarises where we've got to with testing, the work we've done looking at the layout of our chart, what's included in our chart and what's not included in our chart. So really all that's left is to look at what our chart looks like. Now many of you will now be using this, but essentially it's a relatively simple chart. It includes 8 physiological parameters. You can score 0, 1 or 2 for each of those physiological parameters. There are 5 different age ranges, which are clearly printed on the front of the chart. It allows you to build in a standardised escalation of a level 1, 2 or 3 in board, but you can dictate who's included in your level 1, 2 or 3 escalation systems, this will change depending whether you're in a remote and rural board or whether you're in a central board. And I guess the question is, well, so what? Well, we're expecting that each of the boards is now introducing our national early warning score. We're expecting to get some feedback from that. We're inviting that feedback back in from the boards as they're testing, and there's a series of WebEx calls about that to share everyone's experiences of it. Do we think this is the final version? Well, no, not really. We know there's lots of ongoing work going on within PEWS, and it may well be that there is a perfect score just around the corner. What we have done is realise that as a nation we can move onto the same page and have a shared and common language, which we think will benefit our patients and our staff. It also lets us realise that if a perfect PEWS is just around the corner, it will be relatively easy for us to move from one system to the next as a complete nation. Would we do it again? And if we had the time again, what would we do? Well, to be honest, I would wait for somebody to produce the best in class, but we are still waiting for that, and at some point we have to make the moves ourselves, which is what we've done. I'd really be keen to find out which observations should and shouldn't be included, which ones give us the best prediction of the deteriorating patient, which one leads to bleep fatigue the most for false negatives. I would want to have comparative validation in various environments. I want to know what works pre-hospital. Does it hold true for ED? Does it hold true for the front door and PAU? Does it hold true for inpatient units? Does it hold true for all patient groups? I would take all of that information and then add in the human factors work that we've done on chart layout and scoring systems and testing and counting and put all that together, because I really don't think that producing the best in class, which is reliable on electronic testing and normally on retrospective case validation, and going back through things historically, not giving us any of the information about staff or parental concern, etc., and what people felt like at the bedside. I really feel that that patient, parent, and staff understanding, along with the scoring, along with the human factors work, are likely to lead us into a much better system for understanding the deteriorating patients. And my take-home message is always the same at any conversation I have about PEWS, is that actually the PEWS is just a score. It's just a chart, and on its own it has never ever saved a life. What it can do is help staff recognise when somebody's unwell, and if it helps them recognise it, then it should empower them to escalate the patients that are sick to get the right attention to the bedside. Unless a PEWS score and chart helps us do that, it's really not doing our job. I do wonder if we're over-focusing on getting the perfect scoring system, when actually what we're really wanting to do is find a scoring system which makes it easier to do the right thing reliably in all environments. Thank you for listening.